Three, two, one.
We'd like to welcome you to another edition of GrokTALK, brought to you by New Hampshire's leading conservative blog site, GrokTALK.com. We are your feared, extremist, right-wing, hard-charging, gun-toting, opinionated, outspoken, rabble-rousing, letter-writing, radio microphone stomping conservatives and rational libertarians. So get ready for more news and opinion you could only get from GrokTALK.com. GrokTALk. Welcome back to GrokTALK from Concord, New Hampshire. I'd like to remind you to check us out on Facebook and Twitter. Just search Granite Grok, and you can listen to this program. Well, you could be listening to it live right now, but if you missed it, you can listen on Stitcher, iTunes, Spreaker, iHeart, TuneIn, at GraniteGrok.com as we post a podcast, and on Tumblr. So, YouTube. Don't forget YouTube. Yep. A lot of places to listen to the program. No reason not to, because we have great guests, and sometimes we have great returning guests, which is the case today, because we have with us Dr. Jeffrey Singer, who is a surgeon in Phoenix, Arizona. We had him on the show last November, and we've got him back again because he's written another article, this one in the Wall Street Journal, about electronic health records. Dr. Singer, welcome to the program.
Thank you for having me.
Great to have you back. We did talk about electronic health records a little bit the last time you were here, but you've recently revisited the subject, and apparently they're not. They haven't turned out to be what they were billed as.
Yeah. First of all, before we even get started, let me stipulate that I'm not against electronic records per se. I'm against having government-mandated, government-designed electronic records on anybody. So, for example, for years now, business and industry has been going digital. There was no government mandate requiring banks to adopt electronic record keeping or to communicate with each other electronically, and there's no mandate requiring retailers to do that, or supermarkets or dry cleaners. But we're seeing organically this thing happening, and in fact, it was happening in the healthcare field as well. The mandate doesn't apply to dentists or veterinarians, and people who have dentists and veterinarians may notice that a lot of them have on their own gone electronic, and many doctors, colleagues of mine, were actually singing the praises of their electronic system in the doctor's lounge when this law was passed in 2009. And normally when you decide as a business that you think it may make sense for you to go electronic, you hire an IT consultant who comes in and studies your operation and the way you do things, and then designs a program around that to try to enhance and extend what you're able to do, make you more productive and efficient and make less errors. But that's not what happened here. So in 2009, as part of the so-called stimulus bill, a lot of people actually think it's part of the Affordable Care Act, but it's actually separate from that. As part of the stimulus bill was a mandate saying all doctors, hospitals, all providers, in fact, even pharmacies, will go electronic by the end of 2014, or pay a penalty, and the penalty will go up to 5% of Medicare, a 5% cut in Medicare reimbursement. They always use Medicare as the stick, and the system that you had to adopt was one that they in Washington decided will make you better at what you do. So anybody who already had a system had to actually scrap it because it wasn't the system that the government bean counters thought was the best system. And the term that they use is meaningful use, which kind of Orwellian. So in other words, you have to have a system that is meaningful, and therefore all my colleagues who already had systems, they weren't considered meaningful because they didn't follow certain templates and ask certain kind of questions and enter certain kind of data that the government thought would make them better at what they do. So it doesn't matter that they designed something to make them better at what they do. The government didn't think they designed it that way, so they all had to scrap their systems. And so it's like turning everything on its head. Instead of me building a system around the way I do things, making better at what I do, now I have to kind of take what I do and make it fit into their system. It's the reverse. It's sort of like trying to fit a square peg into a round hole. And that's where the problem started, because not only did doctors have to incur a tremendous amount of financial costs, which drove a lot of them out of private practice, because you're talking about six figures outlay of money to purchase these systems, and then you have to take people in your office off of what they were doing, which is usually a productive thing that they were doing, or they wouldn't be doing it, and have them spend the next couple of months taking all of your paper records and scanning them into this new system. But then also, as you and your staff have to adjust to this new system that was alien to you because it wasn't built around you, that sometimes slows you down to the point where you could see half as many patients, sometimes for several months, which is a loss in productivity as well. So many doctors, particularly primary care doctors, threw their hands up and said, I can't do this. And they approach hospitals and say, look, you guys have deeper pockets. You already have an electronic system that you set up in compliance with the mandate. Could you buy my practice out and just put your system in my office, and I'll work for you? And so we've seen that happen a lot. And now something like 70% of doctors are actually employed by hospitals as opposed to being a private practice, that's a separate topic, but that impacts the patient-doctor relationship as well, because the doctor's now torn between his ethical commitment to put his patient first, his professional ethics, and the fact that his employer, the hospital, is pressuring him to conform to the compliance regulations placed on the hospital. And sometimes there's no conflict, but lots of times there is a conflict, and so the doctor finds himself in an ethical dilemma. And not only that, but the doctor is now working for the hospital, not for the patient, technically. But getting back to the electronic health records situation, so this not only did it create a financial hardship, but because of the fact that it's forcing all of the healthcare providers to basically focus on, in effect, filling out a series of electronic forms designed by the government for them that, in their opinion, will make them perform better. It takes your eye off the game. It creates sort of a tunnel vision. All of the focus is on the form. And so there's a tendency for you to overlook important issues and concerns and forget to ask certain questions because you're taken off your game, if you can understand what I'm saying. Anybody in any field should be able to relate to this. So that's, in fact, there's been a lot of peer-reviewed data out lately suggesting that electronic health records is actually increasing errors. In the latest issue of Diagnosis, came out in October 2014, it's a peer-reviewed journal, Dr. Hardeep Singh, who's a nationally renowned quality assurance expert, he's an internal medicine specialist at the Houston VA Hospital, wrote about how they looked into, remember Thomas Eric Duncan, the so-called Ebola patient zero. He's the one who was sent home from the emergency room with Ebola and then died. And he was the one that started off the whole Ebola scare in the United States. Well, that missing his diagnosis was traced to the electronic health record system. Because when he presented to the emergency room and told the triage nurse there that he's from Liberia, he's been around a lot of Ebola patients, some of whom have died, and he thinks he's coming down with it right now, there was nothing in the electronic record template for this. So she couldn't enter this data. So she wrote it down on a note, and when he was sent back to the ER to see the doctors, the note said, make sure the doctor knows about this. But, of course, the doctor went right to his computer screen. And there was nothing in there, and then the patient, assuming the doctor knew about this, didn't repeat that to the doctor, and the rest is history. Completely understandable that you won't think about Ebola in the United States as your first line of diagnosis with somebody with nausea, vomiting, and diarrhea. So, but that's just one, more poignant example. But there's a whole lot of other things that happen because in order to doctors are humans too. So when you're dealing with this cumbersome electronic template, you tend to look for shortcuts. That's what everybody does. So when and the way the system is designed, when you purchase your electronic health record system from a vendor, the vendors promise you, they say, we guarantee that you will meet meaningful use criteria if you purchase our software. So how do I know I'm going to do that? Well, because it won't let you go on to the next item unless you answer the required things by the government. Sort of like when you're purchasing something online and you're entering your credit card data, and it won't let you click submit until you enter your zip code or something like that. So what ends up happening is a lot of doctors, especially, they're running an hour behind in the office because of this thing slowing them down. And there's some data that really isn't relevant to them, but apparently the government thinks it is. So they just put something in there so they can go to the next page. In addition, when I make rounds at hospitals, I see an awful lot of examples of cutting and pasting. So, just the same kind of thing. In order to get through to the next thing, since you have to you have to cover certain topics in order for your hospital visit to be considered a meaningful hospital visit. So what doctors will sometimes do is cut and paste all of those issues that were addressed in someone else's note from a previous day and put it into their note. The only problem is that things may have changed in the last day or two. So that information from a couple of days ago is actually not true anymore. It really needs to be updated, but suddenly it's being replicated. So what ends up happening is you can't really even trust the information in the electronic record because you don't know whether this information is true or it was somebody used some shortcuts and cut and paste information in there. So it makes you. I come home every day nervous that I made some terrible mistake because I either forgot to think of something because I was focusing too much on filling out that record rather than looking at my patient in the face and going through my normal internal decision tree that I normally follow. But in addition to that, I worry that I either missed something in the electronic record or I acted on information that was wrong. And another misconception people have is they think that these electronic systems are all interconnected. And so a lot of people will say, hey, that's great. So in other words, if I show up in any urgent care anywhere in the country, I'm traveling, and I go into a seizure, so I'm unconscious, but they can go look in the computer and wherever they are, and they can find out everything they need to know about me. That's a great idea. It is a great idea. I wish something like that existed. It doesn't. In fact, according to the Department of Health and Human Services' own report this past November, only 14% of electronic health records are what they call interoperable, which means they intercommunicate with one another. And almost all of them are that do communicate with one another are the records between the hospital and the doctor's practices that they own, that I described earlier, who said, come in, put your stuff in my office, and buy me out. That's almost all of the cases of that. So that what happens to me, I'm a private practicing surgeon, and people will be referred to me by their primary care provider for surgical evaluation for something, let's say like gallbladder disease or something like that. Well, since our electronic records aren't interconnected, that primary care doctor prints out the electronic records that he or she has on that patient and either sends it over to my office or sends it over with the patient, and then we scan it into our electronic record system. Well, because for the same reasons, this doctor had to enter all this voluminous data to meet meaningful use criteria. And this data, there's a whole lot of extraneous data in there that it's not really useful to that doctor, nor is it useful to anybody else, but it had to be put in there because the government thinks it's meaningful. So I'm looking at this electronic record sent over to me, and it's pages and pages and pages of information that I don't need, like his uncle on the mother's side of the family once had gout. That's great, but I'm seeing this guy for gallbladder disease. I don't care about his uncle having gout on the mother's side of the family. So I'm scanning through all of these words, and it's almost like scanning through a telephone, the old-fashioned telephone that people used to use, looking for what I need to find. And what ends up happening is a couple of things. Either I just go down to the bottom line to see why he was sent to me, and then I ignore the rest of the record and say, you know what, I can't trust any of this anyway. I'm just going to start from scratch. Now I know why the guy's here. I'm just going to pretend we're meeting for the first time, which we are, and I'm going to start taking a history and physical like nobody ever took one before. We're just going to start from scratch that I need. Or sometimes in the process of scanning over this data, because there's so much in there, my eyes actually scanned over something that was important in there and missed it. And that's important too. So this is what's going on that patients need to know about from a clinical standpoint. So if I'm accused of being old-fashioned and against electronic records, not at all. But I believe that electronic health records should develop organically in a free society with a free market. Businesses make decisions. I'm sure there are certain practices, depending on the size and nature and scope of the practice, that maybe electronic records, for them, doesn't make sense. I know some dentists who have gone electronic and some who haven't, some veterinarians who still use old charts and some who haven't. But these are decisions that individual businesses make, and then when they make it, they usually consult people to design a system to make them better at what they do. That's the whole idea behind it. as opposed to being ordered to fit into a system that wasn't designed for them. So that's the main problem. Now, you may ask, why was this part of the stimulus package? Well, I got a theory. There's a whole lot of companies that weren't doing too well until it's sort of like an Obamacare for electronic health records. Basically, we're being ordered to buy these products. There are a handful of companies that make electronic records, Epic, Cerner, there are several of them, and they sell to the providers, and they're doing great because I'm being ordered to buy their stuff. And they're nice people, and they're sensitive to my problems, and they're trying to help me out with them and come up with ways of making it easier for me to conform to that template. But just the same, this was a nice stimulus for them, a nice business thing for them. Also, a lot of people tend to lump the electronic health records into the Affordable Care Act. Like I say, it was a separate bill, and I don't think it's a coincidence that also part of that stimulus package was the creation of the Federal Commission for the Coordination of Comparative Effectiveness Research, FCCCER. That was also appropriated in that stimulus bill. And what that commission is supposed to do is collect all of this data from these electronic records, and based upon the data and statistical analysis, determine what they think is the most efficient use of resources, allocation of resources, what they call comparative effectiveness. What's a more effective use of the dollar than another? And then the Affordable Care Act, as we know, creates this Independent Payment Advisory Board, or IPAB, which some people have called the Death Panel. This is a panel of 15 appointed people who are under the actual law. They are not subject to congressional review or judicial review, and they're supposed to make recommendations to Medicare regarding reimbursements for different procedures based upon the data given to them by this FCCCER. And so what they will basically do is that technically they're not directly rationing, they're indirectly rationing. So, for example, if their data suggests you get less bang for the buck for doing a total knee replacement on somebody over 75 than under 75, they'll say anybody over 75, the total amount Medicare will pay for a total knee replacement is, let's just say, $1,500. Under 75, we'll pay $15,000. So then, of course, the providers will act accordingly. So technically, nobody can accuse the regulators of rationing. They're not rationing. They're just saying what they're going to pay for things. If they're going to make, but of course they are rationing indirectly. So I don't think it's, to me, in my mind, I'm connecting the dots, and I don't think it's a coincidence that in the same law that ordered me to adopt a government-designed electronic record system that has me enter a whole bunch of data that may not necessarily be relevant to my performance of my practice, in that same piece of legislation was the creation of a panel to collect this data and analyze it and report to a panel that was created by the Affordable Care Act. I just think it kind of all works together very nicely in symbiosis and synergy.
Dr. Singer, I was wondering, do you know, I know they spent a bunch of money on this in the stimulus. Was it just to create the board? Because it doesn't sound like, I mean, the doctors are on the hook for the money for their own systems, and of course the manufacturers and software developers are going to get paid by the doctors when they buy the stuff because they have to. Do you have any clue where the stimulus money went?
Well, some of it went to the doctors, actually. As part of the act, they realized they're creating a financial burden. So they said that if you enact this by, I think the deadline was 2013. I could be inaccurate on that, but I think it was 2013. If you enact this by this certain date, we will reimburse you for the hard costs. In other words, not for the loss in productivity or the extra people you may have had to hire, but for what you laid out for the software and the computers. We will reimburse you for that. But in order to get reimbursed, so that was money for that. But in order to get reimbursed, you have to jump through a lot of hoops. So the way it works is, first you lay out the money. Then you're operational for a few months. You have to have a designated person in your office certify to CMS, the regulating authority of Medicare, that you have met meaningful use criteria 1, Roman numeral 1. And they give you certain criteria. They have, in other words, they have to take samples, random samples of your electronic records, and show, for example, that on every patient who came into the office, you asked about sexual activity. You know, even the 80-year-old lady who sent over for you to lance a boil. You asked about smoking, things like that. And if you haven't done that, then you don't get reimbursed. But that's just for level 1. So you get your first tranche. Then, after you get your first payment, then you, next year, it takes about 3 years. So the next year, you get the second third, providing you've met meaningful use criteria 2, and that gets even more difficult. So, for example, as a surgeon, I'm supposed to certify that my patients that are sent over to me by their primary care doctor have all of their immunizations up to date in my electronic record. Even though I'm not their primary care doctor, I don't concern myself with that, and they're sent to me for a specific surgical problem, let's say a colon cancer, by their primary care doctor, and I'm supposed to concern myself with whether their immunizations are up to date, which is what the primary care doctor does. That's just one example. I have to, if I learn that they're a smoker, I'm supposed to document that I gave them smoking cessation counseling, even though they were sent to me for colon cancer by their primary care doctor. So that's meaningful use criteria 2. And that criteria 2 is very difficult. A lot of doctors can't meet the criteria. If you don't meet criteria 2, you don't get the second and third. But supposing you do, now you go to meaningful use criteria 3. And so you're getting reimbursed for a huge financial outlay over 3 years, which is, you know, from a business standpoint, businesses can't work that way, as you could imagine. But besides that, these criteria are so onerous that most doctors don't make meaningful use criteria 2. After the first tranche, they can't make the second. And those who make the second, when they see what they have to do for the third, they basically at that point, which is a couple of years later now, are saying, you know what, forget the last third, just keep the last third. I'm not going to do this. I just can't afford to do this, and it's just taking me away from things I got to focus on. And so that's what's happening. But that was a part of the money in the stimulus bill was geared towards reimbursing somewhat the providers. I forgot to mention on one other cost. Some listeners out there may see this. Depending on your kind of practice, like I say, let's say you're in primary care, well, this electronic record thing slows you down so much because you're basically having to enter all this information on a form. Sort of like when you go to the DMV and you got the clerk sitting at a computer and he's asking you questions and typing it in as you're talking, kind of filling out the form. That's sort of what you get relegated to as a doctor nowadays. So some doctors, because they don't want it to slow down their flow, and also because they don't want to be looking at a computer screen. They want to be looking at the patient, seeing their body language, making eye contact. That's part of your assessment, looking at how they look. So what they've done is they've hired it's called scribes. They hire people who come with them from room to room, and they have a laptop with them, and they're filling out the electronic record for the doctor. So the doctor will ask questions and then say something to the scribe, and the scribe is typing whatever the doctor says to put in there, you know, in box number 1, put this, that kind of thing. And that's helping the doctor do his or her job and also move the doctor along. But that's an expense. You got to pay for that person, and there's no reimbursement for that. But in addition to that, so I guess that was a stimulus too, wasn't it? It stimulated the creation of scribes.
Yes, it was.
But in addition to that, you know, another concern for patients should be is who is this scribe here in this room? Is this person a medical professional? Because I'm being asked to share a lot of very, you know, sensitive, confidential information here with my healthcare provider, and can I trust this other person here with this information? Or is that person going to talk to his friends about this? You know, so that's another issue that's raised. Oh, and that brings to mind the last issue. All this information that's entered into electronic health record, is it secure? And a lot of people, we all know that, you know, we can't be confident about that.
All right, well, Dr. Singer, we know you have another call coming up. You have to make an appointment. Tons of great information. We could keep you on forever. I want to thank you for coming on the show, but we're going to let you go so you can take care of your additional business.
Well, thank you. If I could just say one last thing.
Mm-hmm.
Hopefully, depending on the King versus Burwell decision or the outcome of the next presidential election, we're going to be able to repeal and replace Obamacare. If we do, that still doesn't address this electronic health record mandate. So that's another reason why I wrote about this. Congress needs to know that they need to repeal that mandate and let doctors continue evolving their own electronic health record systems that was in progress before this thing happened. And it's going to take a separate action.
All right. Well, thanks a lot. You have a great weekend.
Pleasure. You too.
Bye-bye. All right. Thank you very much, Dr. Singer. You took your headset off. We're not done with the segment. He has to leave early because he needs to take another call for another show. Okay. So we can fill the next 2 minutes.
Yeah. I was going to bring up or ask the question. I ran out of time, but, in listening to him talking about the different tiers of questions and actions that have to be done by supposedly independent doctors, which are now nothing more than employees, this is the continuance of the absorption of the private sector into the public sector, because it basically makes the doctors nothing more than agents of the government.
Mm-hmm.
That
especially the data collection stuff.
Yeah, especially, asking the questions. The next time I get asked by some pretty young things in the doctor's office, how they do the pre-examination prep, the weight, they ask you these questions.
Take your blood pressure, temperature, etc.
It's the asking of the questions like, well, do you own any guns? Well, I have an A10, CVN 45, all these things that and it is a she in my office that I go to. It's like, I just can't wait to explain to her, yes, I own my own nuclear-powered aircraft carrier.
Yeah.
or
you can just write yes, because yes, I do. I do own guns.
I've applied for the same Obama waiver that Iran's going to get, and I plan to create some peaceful nukes.
That's
to
right.
Deter
Peaceful nuclear energy production
to ward off evil spirits.
Yeah. I just look at that and I go, I really feel sorry for these guys, but a lot of them are getting out. And, there are going to be lots of unintended consequences, like the Seattle minimum wage of $15, just like we talked about earlier. As it was pointed out, we see things as connected, as conservatives. You can't disrupt, and engineers and techies, because we live this stuff. You can't change something over in one spot here and not have it affect something over here. We have to think through these steps. As engineers, we get it mostly right most of the time.
And you have to also understand that we're talking about an economy of over 300 million people, all of whom will have dynamic changes in their relationship to their neighborhoods, their buying habits, constantly. You cannot manage that. It just can't be done.
After 3 centuries, Adam Smith's invisible hand is still at work.
Absolutely. All right, we're going to call Mark Meckler, and we'll be right back. Stay tuned. This is GrokTALK.
Senator Jeanne Shaheen said, if you like your current health plan, you can keep it. That's not true, Senator. 22,000 New Hampshire citizens have been kicked off their insurance plans. Hospitals in Rochester, Concord, and Portsmouth, they aren't allowed to provide care under the exchange. Senator, you were wrong in your comments. You should apologize for your misleading remarks. I'm calling Senator Shaheen at 750-3004 and telling her I want my doctor back. You should too.
Paid for by saberpac.org, not authorized by any candidate or candidate committee.
We are struggling. Rising healthcare costs are part of the problem. Senator Jeanne Shaheen helped create this mess we're in. As a state senator, her bill chased 21 insurers out of our state. It reduced our choices, raised prices for New Hampshire families, and when Jeanne Shaheen supported Obamacare, it limited access to 10 of our 26 hospitals, reducing our choices again. Tell Jeanne Shaheen she's made healthcare worse. Few things are as important as finding the right doctor. And under Obamacare, that's harder than ever. Over a third of our hospitals no longer available. Our doctors no longer covered. Fewer choices, longer drives. No state has been harder hit than us. And even after watching it impact New Hampshire, Congresswoman Ann Custer still supports it. Call Ann Custer. Tell her Obamacare isn't working for New Hampshire.
This is a coalition of New Hampshire taxpayers. We're located at 8 North Main in Concord, New Hampshire. This is a repository for all things conservative and municipal. So if you have a problem in your town, your school, your budget committee, the right to know law, and now at the top of our list is voter fraud. You have a tip for us, some information for us, you want to join or help us out, cnht.org.
Grok TV.